Hello and welcome to Caregivers Corner. My name is Helen and I'm one of the social workers at the McCormick Dementia Services. When caring for someone with frontotemporal dementia, you may be experiencing some behaviors you may find challenging. Today we will be discussing a loss of inhibition. At times this can present itself as sexual in nature. This may include touching people or making comments many of us would find inappropriate. To help us understand why these changes in inhibition occur, we will be hearing from Alex Douglas, who is a registered nurse, and Lisa Jaworski, who is a therapeutic recreation specialist. Both of our guests work with the behavioral response team. Thank you, Alex, for joining us today. Some of the folks who are caregiving for somebody with FTD have talked about how difficult it is for them when their person is making comments or touching others in what might be considered inappropriate. Why does that happen? Can you give us kind of a medical perspective on that, Alex?
Absolutely. So it is obviously a very challenging behavior for caregivers. And one thing that we have to kind of acknowledge first is that the vast majority of humans do have sexual drives and sexual thoughts and feelings. And that doesn't go away when you have dementia. Not always. Sometimes, yes, but not as a rule. I guess one of the challenges that we see is that a person with FTD, frontotemporal dementia, I'll say FTD from now on, is that due to changes in their frontal and temporal lobes, what we may call their filter starts to go. So I guess first we should probably cover what the frontal and temporal lobes actually do, to understand from a medical perspective kind of what's happening and why. So in the frontal lobe, it's around the front of your head, right here, goes back a certain amount there. It's kind of right at the top there. It's the largest of your four lobes in your brain, or four major lobes rather. And of that, the two kind of parts that we're going to be most relevant for today are the gyrus, which controls self-awareness, language production, comprehension, and inhibition, and the orbitofrontal cortex. And that controls your flexibility, inhibition as well, your social behaviors, emotional appraisal, adaptive learning, and reward/punishment for behaviors. So the example I always give is that part of the brain kind of helps you learn that if you touch a hot stove, you're going to get punished, but you're going to get burnt. And from the same perspective, if someone is experiencing frontotemporal dementia, they might have lost their filter, whereas before they might think, hey, this is a very attractive person, but kept that to themselves. With their social awareness and their inhibition maybe not as strong as it always has been, they might just say that instead of just thinking it. Or they might act on and say, oh, well, I'm going to touch this person now because I want to. Whereas the part of the brain that might say, hey, we probably shouldn't do that, is maybe not working as well as it should be. So those changes to filter, and also having the reward and consequence part of our brain maybe a little bit impaired as well, might make us do things that we normally wouldn't do. So part of the challenge with this is that there can be kind of two vague reasons as to why someone might be having what you might call sexual behaviors. It might be hormone driven, so they actually are having sexual urges and are acting on them. Or it might be things that we are misidentifying as being sexual behaviors because we're coming from that perspective. So staying on a bit of a medical kind of lens, if someone's having any discomfort or pain or changes in their genitals, they might be more likely to touch themselves. And it may not be from a sexual standpoint, may just be from a discomfort and trying to soothe standpoint. Some ones that we see often are urinary tract infections, really common. If someone's having one of these, they might have their hands down their pants because it's really uncomfortable, it's painful. And if we don't know that there's a UTI happening, we might think, oh, that's really not great behavior. We can't be having that. Other common things are pain from, say, any sort of injury or skin breakdown. If you have someone who's sitting in a product that might be soiled for long periods of time, you might expect to see their skin break down, causing discomfort and possibly itching, which might as well have them have their hands down their pants. A third kind of physical thing, which many people don't like to talk about, is STIs, so sexually transmitted infections. Now, in many generations, this is a bit of a taboo subject. And can be something that might be really uncomfortable to bring up, to say, you know, you might have an STI, which may have had for many, many years, and is now affecting them more and more, which might cause more discomfort. Other things that we see, not as often, but sometimes, are vaginal or rectal prolapse. So once again, you're having pain, discomfort, your hands going down your pants. Another possible thing that might be to touching others, if it's not from a hormonal standpoint, is seeking sensation. So that, in combination with changes to our proprioception, so where our hands are, and our eyesight, might mean that someone is reaching out to try and get contact with someone and might be inadvertently touching someone inappropriately. We see this sometimes with individuals who are in wheelchairs, because if you're in a sitting position and you have someone standing right in front of you, if you think about where your eyes now are, there's a very good chance your eyes are now either at chest level or your hands are at genital level of the person who might be trying to interact with you. So that can be a source of some misunderstandings. And that being said, from a more hormonal sexual standpoint, as the filter, as we say, is going, you may act on those urges. And as we have less empathy towards other people, which is sometimes a trait of FTD, we might not realize that the other person might not want us to talk to them that way or touch them at all. So it really can be a combination of changes to your filter, your empathy, your self-awareness, or physical factors, which might make you want to have these behaviors.
Okay. So I guess the person with FTD can also be misinterpreting what people are doing, right? So if you happen to be providing personal care, that might be misconstrued as, you know, you having an interest in that individual, right?
Absolutely. Yeah. So I think that if you were, so let's say that you are having more challenges with your social awareness and you aren't understanding what's happening around you. So taking away dementia and brain changes, if you are laying in bed and someone is touching your genitals, the assumption for many parts of the population might be that this person is trying to initiate something sexual or intimate with me. So by misunderstanding the context and social awareness, the person might think that you're trying to initiate something sexual, you're trying to care for them. One thing that we see too is, occasionally, is if we really do teach that it's good to get down at eye level with someone, no matter who they are, and meet them where they're at. And sometimes we see, sometimes with female caregivers, that if they are bending at the waist and getting right in front of someone, you might inadvertently be having your cleavage right at eye level. And if you're lacking that filter, they might just think, I'm going to go for that, or they might not normally do that. Now, of course, we aren't going to victim blame at all. It's not it's not the fault of the person that they're being touched. We don't want to ever say that. But in some cases, we do suggest bending at the knees, get down low to someone, just to protect yourself and to help the person who's having these behaviors to not have a target right at eye level. It's a bit of a sensitive subject, but it is something that I do find can be helpful and can be a bit of an aha moment for some caregivers as well.
Okay. So essentially, Alex, I know I've talked to a number of caregivers who have found that, these are spouses that would be talking to me about the increased desire for sexual relations, and essentially, they don't want that. They, basically it's, I'm tired, I'm providing care for you all day long, and it's basically, I'm just too tired, and it's hard to move out of that caregiver role into an intimate partner role.
Yeah.
Is there anything that can be done to, I guess, reduce the hypersexuality that is happening in an individual?
So it's challenging, and a lot of that, I guess, a lot of what you'll need to have success is knowing the history of the person, kind of knowing where they're coming from, what were possibly their norms or their desires before the brain changes have happened. One challenge as well is in some generations, there's a lot of taboo around masturbation. Whereas if a person with FTD is comfortable and able to masturbate, and they wish to, and as long as they're doing it in an appropriate setting, then that can be an effective way of addressing some of these hormonal sexual needs. We have found some success in creating stimulation for other parts of the body. So if it is less of a hormonal sexual need and more of a want for stimulation or companionship, things like doing a hand massage with lotion can be really effective in giving them that touch without necessarily becoming sexual. Things like back rubs as well can be very effective. Or just having activities that they enjoy to offer some distraction. Now, from a medical perspective, there's a part of your brain, the gyrus rectus, which there is some evidence that might be closely related to sexual drive. So if the FTD is affecting that part of the brain, that might be kind of hardwiring them to have more sexual behaviors, or in some cases actually less. So you actually can get a hyposexuality at times from these changes to your brain. One thing that I haven't talked about too much yet is that sometimes these sexual behaviors can be a result of boredom or understimulation. Not always the case, but sometimes we can try to self-stimulate if we're lacking other stimulations. Or if we're bored, we might want to touch ourselves or touch others or initiate or attempt to initiate intimacy with our loved ones or caregivers, because that might seem like something that might be fun and engaging to do and meaningful. So by offering other things that they'd like to do, we might help to distract them from those needs.
Now, I know that some of my caregivers are wondering about, if, let's say, their spouse starts talking about their daughter or granddaughter in a sexual way, they're not exactly sure how to deal with that. And is it as a result of what's happening in the brain, or have they all of a sudden developed some sense of pedophilia?
Yeah, so it is a brain change. And I know that we always say, don't take it personally, and it's the disease, not the person. That can be a really challenging thing to do when we're having sexual behaviors or thoughts voiced about family, in particular about minors. It can be really hard to separate the person from the brain changes when it's something that's very taboo and very sensitive. But ultimately, it is the brain change is not the person. Well, let's just say don't shame people. Maybe distract or say that's not appropriate, but we don't want to shame them. We want to say, how dare you say that? That's your granddaughter, you monster, you pervert. Ultimately, it's not going to change how they feel, and it's going to make them feel very bad themselves, and it might actually damage your relationship with the patient and make it more difficult going forward to provide care or to have those meaningful relations. Because ultimately, a big part of this is changes to the brain in the filter and in your social awareness, and it might as well be kind of depending on where they might be in their disease progression, they might be misidentifying these loved ones as non-members of the family.
Okay.
It all kind of depends on where they are, and everyone's different.
Okay. So is there any sense that they would carry on that kind of behavior for, you know, years to come towards their daughters, granddaughters, sons, grandsons? You know, I don't want to stereotype because it does happen the other way as well. So
it does, yeah. So I'd be hesitant to kind of put a roadmap to things, but often these things might kind of come and go. So you might, in some cases, you might see a long preservation. Often you won't. Often it could be, it might be in the moment they're saying, like, you know, weird things, and they might move on to something else or someone else. So I think one thing to realize about this is that we aren't going to ever really teach them, like, hey, you know, don't say that about your granddaughter. That's not going to do anything for you. It has to be, we have to change their environment and change the way that we react to minimize the risk to those around us and to hopefully keep everyone, including the person with dementia, safe.
Okay. All right. So basically, it really is not that individual's fault. It's because of the brain changes, because of the dementia, the lack of filters, and just, you know, being able to, you know, read another individual. Like I often will talk to caregivers about the fact that there is like no awareness of how somebody might be reacting to that. Like, you know, they don't see that emotional outcome on the face, right? Like,
yeah,
identify it that way as like, oh, I shouldn't be doing that, or I shouldn't say that.
Absolutely. And it's all coming down to changes in your gyrus and your cortex. There is one kind of prominent dementia educator, I'm not sure if we can name names or not, TS, we may know her, who says that if our head were to shrink with our brain, we'll have a lot more empathy about behaviors that loved ones might be having. So if you had, your head all of a sudden was the size of an orange, because it had shrunk down with brain changes and losses in brain mass, and you were being inappropriate in public, people might say, ooh, okay, well, look at that. I mean, it's probably not their fault. They're probably not doing this on purpose. They can't help it.
Yeah.
One challenge with dementia is that this isn't the case with dementia. And unfortunately, sometimes people who don't know the situation might jump to conclusions or confront people about their behaviors, which can be really challenging for both the caregiver and the person with dementia as well.
Okay. One other thing that I do recall, one of the really great communication individuals is Dr. J.B. Orange, and many of the caregivers are very familiar with the stuff that he teaches, but I just wanted to share that one conversation that I had with him. It's like, yes, a lot of language and communication happens on the left-hand side of the brain. However, all the swear words seem to be located on the right-hand side of the brain. So have you heard that, Alex? You know,
I have, yeah.
Okay.
Yeah, and I've heard as well that often the things that we kind of throw away in our brain as being taboo or inappropriate are some of the last things we hold on to. And as we lose our brain ability to have kind of more as polite or more socially acceptable conversations, we might instead, when we can't say a word, reach for something else instead, which may not be appropriate for the context or the audience.
Yeah. Okay. All right. Well, thank you, Alex, for your time and sharing that wonderful information. I really appreciate it.
Yeah, my pleasure.
All right. Thank you, Alex. Lisa, thank you for joining us today.
Thank you for having me. It's a pleasure once again.
Have you come across this issue when you talk to care partners about their person being disinhibited? What kind of interventions might you suggest that they try?
Yeah, that's a tricky one. I know that one thing that's been, well, helpful, it doesn't fix the situation, but helpful is to have, like I'm sure well, I know McCormick has these, but little cards that share information. So with people who wouldn't necessarily know the individual, say you're out at a restaurant or you're even going for a walk in the park or whatever it might be, if you know that your loved one is, has that tendency to maybe reach out or touch somebody or say something, and maybe you're in the situation where, it's not just going to be a fleeting moment, it's maybe worth just passing them a little card that says some information about what's going on. My loved one has dementia, or, it doesn't have to be anything too detailed, but I know that they can refer back to you for more information about those and where to get them from. But that's something I think that just helps relieve that sense of stress that other people don't necessarily understand what's going on. Something else is, I think, also being aware that our language can make all the difference. So not always is a person disinhibited in the way that I think we assume. So for what I mean by that is, we might think, or it might look like a person is self-soothing themselves, and maybe that's the case, but there are some situations where it's not necessarily masturbating. It could be more issues where maybe the person's itchy or rubbing. So really being aware on what's going on and what the person's experiencing, because it might not be what it seems. So really knowing the difference between those and how we can address those concerns. So maybe the person has to go to the bathroom, or also thinking maybe the person's hot. So if they're, pulling at their clothes or trying to strip off, there could be another reason for that. So ruling out some of those other factors is really important. The other thing that's not helpful is scolding or talking down to a person because of these behaviors. So really helping the person either redirect their attention. I've had situations where individuals will either give you a spank or want to kiss you or try to, get closer in some way. If you can provide an alternative and redirect their attention, like, oh, hey, offer a handshake, which I know that's probably questionable these days, but having another alternative that they can do instead can be really helpful. One of our doctors, I know, he would go, hey, well, no, let's do a fist bump, so providing something where the person still feels connected, but it's not necessarily inappropriate or uncomfortable given the situation. Removing visual triggers is another one. So you can't always control this, but understanding that, say in professional situations, if staff, for example, are dressed a certain way or more provocatively and maybe not tending to be that way, if there's any any little hint of something, a person with especially FTD is going to focus on that and point it out. So whatever you can do to reduce those triggers would be helpful. So, wearing maybe higher tops, or also we need to get a little bit of a thicker skin on responding and how we feel in those situations. So I've had lots of, things said to me on what your teeth look like, or, how the size or the shape of a person. So trying not to let it get under your skin and moving on, because when you make it a big deal, that kind of feeds into it. And so if they know they've upset you, not that they're doing it on purpose, but you're dwelling on the situation, they're going to go along with that as well. So the quicker that we can change the subject, the better, because it helps refocus the person's attention. Some other ideas. So again, diversional activities like painting, word searches, crosswords. A lot of the times numbers are really successful, or counting. So paying attention to what the person does successfully. And if we can say, hey, I really need your help with something, come with me, and redirect them that way, then you're not focusing in on the inappropriate behavior, and we're allowing the person, promoting and empowering them to do something that's more successful and more appropriate. What are some other ones? Do you have any thoughts so far on that, Helen?
So when you were talking about the restaurant, you know, one of the things that I learned earlier on in my career was that one of the strategies that you can use is you definitely go at times when the restaurants are really crowded. So more of those senior type hours.
Yeah, good idea.
Yeah, so that would be one strategy. Another strategy is going to places where there is typically like a booth, right? And you have the person with the dementia sitting on the inside of the booth, so they can't actually get to their hostess or
yeah, good point.
you know, so that's one of the strategies that people can try. I know that professionally, the recreation team has been pretty amazing, and they're pretty close quarters sometimes with people. And you know, I've made the suggestion where they wear their name tag up higher on their shoulder, so that it isn't down low and directing the eyes towards certain spots on women. Also, the PSWs, they're doing some very, very, you know, intimate things with people. And so they have to, I guess, explain exactly what they're doing and why they're doing it. Because, you know, someone may misinterpret what's going on. And
absolutely. You can misconstrue what that message is, right? If somebody else is telling you to take your clothes off, well then why aren't you? Like, what's going on here, right? That makes sense.
Yeah. You know, we have to think about these things outside of the box and how it appears to that person with the dementia, right? It isn't that they necessarily, you know, want to do that with everybody in that.
That's right.
You know, basically, there are certain messages that are being sent, whether we want to think that way or not.
Right.
And the other thing is that there are no filters now for people with, especially frontotemporal dementia. You know, that's where we have our social controls in the frontal areas of our brain. And so, you know, it just makes sense that, you know, this fellow or this gal is going to actually say, hey, that's a nice looking person and I want to say something. And before they would have basically not said anything, whereas now, it comes out, right?
That processing is gone, where you just say what's on your mind.
Absolutely.
And
sometimes we get that with children, right? And not to say that our folks are children, but they can be very childlike sometimes and have that innocence, right? Where, I'm just going to say whatever. And
that's right. I think the more calm we can remain in situations like that and try to not feed into the shock value is helpful, you know, like rather than make it a big deal, the more we can just sometimes too, and not to make it a funny matter, but a sense of humor and just being a little bit lighthearted with the person can go a long way. So rather than, you know, you shouldn't do that, just going, oh, you know, like what would my husband think of that? Let's, you know, we better not do that. And making it not like the person's done the most terrible thing ever, and being able to move on with it just with a sense of humor, kind of giving the person the benefit of the doubt, you know, like in a normal situation, if that were to happen, like,
Yeah,
Maybe not a good idea.
yeah, I've chuckled a few times, and anybody that knows me, it's basically if one of my clients told me that, you know, I have a weight problem, I would probably come back with, yes, I probably shouldn't spend as much time as I do at the buffet, right? So, you know, it's basically, yeah, treating it with a sense of humor and
Yeah,
not taking it to heart. It is not intended to be a personal affront to individuals.
yeah, yeah. And it's not worth fighting over. So the other piece is that when we're interacting with somebody who has a dementia,
Mhm.
we're the ones, the person with the healthy brain is the one responsible for how that interaction goes. And all I mean by that is we know better, where the person with dementia may not have that ability to really understand right from wrong and how to follow through and execute on something in decision making. So instead of fighting with the person, if we can somehow figure out how to let it go and move on, the more successful I think we're going to be.
Right, right. One of the things that I do have to counsel some of my caregivers on is having a safety plan,
Yeah,
because sometimes, you know, having no filters and not having that sense of inhibition sometimes can put them in a dangerous situation. And so if there are caregivers out there that are experiencing that, I would strongly suggest that they connect with either us at the McCormick Dementia Services or someone at the Alzheimer's Society
yeah,
to talk about safety planning.
absolutely. Yeah, if you're not comfortable, I mean, even if it's not a even if you're at home and you're in that situation where you feel scared, I mean, yeah, like what you're saying, the safety plan where it may not necessarily always be a good idea for the person to be alone, but sometimes you have to weigh out the risks. And if it's safer for you to leave and make sure the person's safe without you there, then that's what you need to do. You need to make sure that you stay safe in any situation like that.
Yeah,
Yeah,
absolutely.
yeah.
Absolutely. Oh, I want to thank you for joining us today. That's a
Thank you.
great information again from you. As always, whenever I've interacted with you, Lisa, it's always been great information. So I
Well, it
want,
goes both ways, so thank you.
and I would like to thank both of our guests today for their excellent information.